Good morning, colleagues. This is Pat Quigley's voice. I'm so delighted that you've joined us today for this session, this lecture, as we talk about clinical applications of research and evidence during your care week. I hope you had a great session yesterday. I'm so excited to be with you today. I can't thank Joe Rust enough. We'll be starting in just a few minutes. We start at 10 after 10. But I just want to thank you again so much for joining us. And I'd love for you to chat in the chat box. I've already gone ahead and placed a welcome there for you. There's Joe. Hi, Joe.
Hi.
How are you?
Fine. Sorry I'm late.
Oh, no worries at all. I just started chatting. You know me.
Yes, I do. I just want to let you all know that Pat is an esteemed colleague. She's known around the world for fall prevention, and she told me just to tell you, she's a nurse's nurse. She's a rehab nurse, and she does not give up on fall prevention. So I'll let her proceed with her presentation.
Oh, Joe, thank you so very much. And I know, you and I go back a long way, Joe. And colleagues, I just want to tell you how honored and privileged I am when Joe Rust asked me, my colleague Joe Rust asked me to come and present with you for Care Week. I do hope you're having a very special Nurses Month. But you know what, colleagues, I want to say one of the advantages of belonging to professional organizations is all the colleagues that you get to meet, the relationships that you build over time. And that's how Joe and I are. We've known each other over the years through the Rehabilitation Nurses Association. And I just want to say, Joe, thank you.
You're welcome, Pat.
And I also want to do a shout out to Dr. Dawn Newman, because it's Dr. Dawn Newman who talked with me with this presentation with Joe there and asked me to be able to present to you true clinical applications of research and evidence. So that's why, in keeping with my specialty area in fall injury prevention, that's what I'm really focusing on for this short period of time that we have today. So I am glad to see you chatting. Everyone, thank you so much for being here with us. I won't be able to keep up with chat questions, but Joe will help me monitor those. But hopefully we'll have some time after my presentation to be able to ask any question that you might have questions and be able to answer them. But if there are questions, I want you to see on this slide here, you have my email. You can contact me anytime, colleagues. Joe knows that my performance measure is to respond within 24 hours, and I'm really pretty good at it. So if you need help, when I come and go in a day with an hour's presentation, I know that there's going to be some other questions. So please know that you can contact me. I'm just delighted to help you in any way. So we are going to talk about population-based approach to fall injury prevention, and this is going to be translating evidence into practice. So my outcomes for you for this, again, short time that we have together, and I could go on about every one of these topics, is to summarize evidence-based fall prevention practices, but I want you to differentiate fall from injury prevention practices, because these exemplars that I'm going to showcase for you are about injury prevention. So I'm going to take you from science to implementation for the short time that I have with you, but I want to be clear that I'm focusing on injury prevention because we can't prevent all falls. So what we want to do is if someone does fall in our care, that they will not experience a serious injury. You can improve healthcare function. Ultimately, you can't prevent all falls, but when you mitigate and eliminate the issues surrounding the risk for injury, then you're able to improve function and ultimately be able to improve independence. So we know that people are falling in our care. I say to everyone that this is an orphan issue, and that's why I'm the nurse who won't give up on falls, because it's a chronic issue in patient safety. And people are still falling in our care, no matter where it is, in the ER to the critical care, in all settings of care, long-term care, assisted living, in the home. So I'm the nurse who won't give up on it. But, for my world, we knew in the Department of Veterans Affairs, which is my legacy, that you can't prevent all falls. My legacy is taking care of those who bore in the battle for us and others to be free. And if you think they're all going to call you for help, you got to think twice, because they're fiercely independent. So our commitment always was to be able to protect people from getting injured. So that's why the focus has been protecting from injury when people fall in our care. So before I actually showcase these exemplars, my 3 scenarios of creating the evidence, conducting research, creating the evidence, and integrating this into practice, I do want to do a refresher of the grading systems. Because, not all published literature, not all published science is good science. So you have to know that there are 2 different rating scales. And this is important when you're thinking about clinical application of research and evidence, because you have to know the strength of the evidence. So there's 2 rating scales that you should always use in your organization when you're determining what evidence to integrate into practice. The first rating scale that I'm sharing with you is from the Agency for Healthcare Research and Quality. And this rating scale is a rating scale that helps to determine the level of scientific rigor, the level of methodological rigor in conducting the research. So the highest level, as you know, is a meta-analysis, the synthesized literature review, where you have lots of studies that have been published, you have inclusion and exclusion criteria for which studies are going to be included in your meta-analysis. So that's published, the inclusion and the exclusion criteria, but there has to be enough published literature to be able to even conduct a meta-analysis. The second highest level of evidence is a randomized controlled trial. And you know what those are. I mean, you have an intervention group and you have a control group. So in the world of fall prevention, this is very hard to do, randomized controlled trials, because quite frankly, trying to control all things and hold them constant while you test an intervention is very difficult to do because of how diverse our populations are, our settings are, our context of care. But that's the gold standard, is a randomized controlled trial. I'm going to challenge you on this, though. The third level of evidence is well-designed quasi-experimental studies. I've done some of those. I've actually done randomized controlled trials as well, but I'm just for different populations and in ambulatory care. But, well-designed quality improvement studies or quasi-experimental studies, there's just no randomization. You don't have a control group. Level 4 is your descriptive studies. So that can also include qualitative studies where you're trying to uncover themes. So that's going to be a lot of the literature that you see published in fall prevention, where you have percentages, looking at relationships, correlations. That's going to be all descriptive kinds of studies. But I want you to see level 5, because level 5, ladies and gentlemen, is a level of evidence. This is the evidence that you make decisions every day on, because you don't have literature or studies to support every clinical decision you make as a nurse. And to all of my nurses on the call, by the way, Happy Nurses Week, Happy Nurses Month. So, but for all of the people, everyone on the call today, you make decisions as clinical experts, but you have to appreciate that not everyone has the same level of expertise. So the level of knowledge that a novice nurse has is very different, of course, than an expert nurse like Joe in rehabilitation. So, but be clear that level 5 is a level of evidence. So this is the level of scientific rigor. So oftentimes in fall prevention, we don't want to make a decision to implement something into practice just based on one study with a small sample size and very little power and hardly any statistical significance. So that's the point. A lot of times when people are implementing evidence-based practice, they start looking at one study and think, oh my goodness, this is enough, but it's not. So you have to really appreciate what's behind scientific rigor. So let me take you to the most important rating scale. This rating scale, the second one, is the one where you actually look at how strong is that evidence, that it's so strong that it's good evidence and we should include it in our practice. So this is from the United States Preventive Services Task Force. So they make recommendations based on strength of evidence that this is something that we should include into our daily living, for example. So we all know in the world of fall prevention that the single most intervention that's so important is to exercise and to incorporate exercise in our lives. But who doesn't? But that's the importance of knowing that we should talk to all of our patients about the importance of exercise, because we know that the evidence is so strong that we should recommend it to everybody to be exercising within the capacities that they have. So that's grade A evidence. So grade A evidence is truly, that's the gold standard, that there has been so much evidence that you've got the synthesized literature reviews and meta-analysis, and we all know that we should be doing this. Level B evidence is the level where you have the evidence that it's looking pretty good. I mean, it's at least fair evidence, so you should consider it. So that would be the example of vitamin D, but how much vitamin D should we be taking to help prevent, it doesn't prevent falls, but to create healthy bones, if you will. So we should be talking to people about vitamin D. Look at level C, because this is like the line of demarcation, if you will. This is the cutoff. Level C is in the face of having no recommendations because there's not much science out there. But we're going to go ahead and we're going to balance the benefits with the harm, because you know what? We have clinical expertise. So we know from our practice, and this happens a lot, that we think that we should be doing this because we think that there is more benefit than harm. So that's what level C is. You make a decision because you think that it will benefit a patient. So look at level D. Level D is when you should not be doing something because the evidence, even that is not effective, that there's more harm than benefit. And then of course, I is that it's insufficient. So the examples that I'm going to share with you colleagues now is going to start out at level C. When we started implementing interventions and testing interventions and building the science, there was very little research out there. So biomechanical research on injury prevention, you have lab-based studies that you're doing. So we kept on conducting the research to see how protective they are against preventing injuries. But we started out in level C thinking that anything we were going to do was going to have more benefit than harm, because right, if there was any more harm than benefit, wouldn't we stop doing something? So I'm hoping when I ask you the question, if there's more harm than benefit to something that you're doing, wouldn't you stop doing that? So as I give you that example, there is more harm than benefit to using bed alarms for everybody who is at high fall risk. You should not be doing that. There is evidence that you should not be putting non-skid socks on patients with a shuffling gait or can't feel their feet, because we know that that creates more harm than benefit. So in all of the decisions that you make surrounding fall and fall injury prevention interventions to implement at the point of care, this is where you should always be deciding between C and D, because quite frankly, we don't have a whole lot of evidence for a lot of what we do in fall prevention. So that being said, it is important to stay up with the literature and to know the evidence. So let me keep on going. Because as I mentioned, randomized controlled trials are indeed the gold standard. But in the world of fall prevention, there's this over-reliance on it. So, you don't, as you know, and look, I love this article back in 2003, that if you were in a plane and you needed to jump out of a plane, you want a parachute, right? I mean, you don't have to have a randomized controlled trial to know that a parachute can save your life. So, that's the point, is you don't need a randomized controlled trial to know that if you fall onto padded flooring, that's going to absorb, that's not going to be as injurious, have as serious an injury as if you fall onto concrete. So there comes a point in time in the work that you're doing in translating research and evidence into practices that you've got to use common sense as well. So sometimes in the world of evidence-based practice, there's just so much over-reliance on this evidence that people stop even thinking about what makes common sense. So this is why I said to you, we know that if you fall on something that's padded, it's going to have less trauma to us. So I'm going to take you back in time to the David Oliver article, 2010. And this article is one of those synthesized literature reviews, grade A evidence and scientific rigor. And David Oliver is a renowned geriatrician out of the UK. I've worked with him in the past. He was president of the British Geriatric Society. And when he updated a 2006 synthesized literature review for this one in 2010, where he opened up the criteria for what studies he wanted to include when they came up with recommendations, more cohort studies, focus on dementia patients. So you read through his article. I always tell everyone too, because since he and his team published this article, it is the foundational article cited in every single fall prevention article since 2010. But you get to the very end and you look at what are the best practices. And I frame everything around this because it can guide all of your work there at your rehab hospital. Is all of us should be implementing interventions that create a safer environment. The flooring, the lighting, all of that is to create a safer environment. Well, when you create a safe environment, you're reducing one type of fall, the accidental fall. The second recommendation is that all of us should be working patients up for their risk factors. So that's modifiable risk factors. So, my impaired vision, my sensory neuropathy, my postural hypotension, my centrally acting medications. I don't have all those, but I just want you to hear me, how different it is to talk about risk factors. Some are modifiable, some are not. So once you identify those risk factors, what you're supposed to do, colleagues, is implement interventions to mitigate them. So you can't be implementing interventions based on high, moderate, or low risk. What you have to do is implement interventions based on specific fall risk factors, because the true essence of our success in any care planning is to mitigate and eliminate risk. If you're not mitigating and eliminating risk factors, then people are going to fall. So these two recommendations are for the anticipated physiological fall. This last recommendation, which I have highlighted for you in the red, is that Dr. Oliver and his colleagues said, all of us have a responsibility from the synthesized literature review to implement interventions to reduce the risk of injury for those who fall in our care. So I want you to hear these words, that we have a responsibility to protect people when they do fall from having an injury. So that's why protecting from injury is separate and distinct from fall prevention. You can't prevent all falls in rehab. You can't. In rehab, we have a high repeat fall rate population, but patients should not be falling because of the same reason. So you have to mitigate and eliminate risk factors. But if people do fall in your care, it's our moral imperative to save their life, to reduce the severity of injury, because it's the injuries that result in loss of function or loss of life. So this wording is very clear. Interventions to reduce the risk of injury to those who do fall in your care. You anticipate people are going to fall, but if they do fall, you just don't want them to get injured. So what we know from the evidence is sitters don't prevent falls. Everybody knows that. You should, in today's world, sitters should be repurposed and retrained to be early mobility assistants. Don't put sitters at the bedside. They don't work. We know that. The evidence supports that intentional rounding doesn't work. You've got patients who, need to be rounded on more frequently than hourly or 2 hours. And who knows if someone who really needs to be rounded on hourly or 2 hours. But the literature is weak. And this is a synthesized literature review from 2019. So you got to do something different. You've got someone on a diuretic, waiting to toilet them every hour is too long. You have to individualize that. Patients' own footwear is safer than having them in non-skid socks. You should never put non-skid socks, as I mentioned, on someone who can't feel their feet or someone who has a shuffling gait. We know that. We also know that nationally adopted interventions to reduce preventable falls and fall-related injuries require that every single patient have a specific fall and fall injury risk factors identified so you can implement interventions to mitigate and eliminate them. We should all be integrating new systems and devices that better predict falls and bed alarms. We all know bed alarms don't work. So that's where you get into your video telesitter technology, webcams. There's other technology that we have at the point of care to help us, help the nursing staff. And there are system-based approaches that actually work, get a toilet them, wake them and take them. Time toileting for those who really need to have it. You don't need to have a time toileting schedule for me. I'm independent, I can get up to the bathroom on my own, but there are certain patients who need to have help, and it's not everybody. I can do a webinar on that whenever you want me to do that. But this, colleagues, as I share this literature from you, I am talking to you about the science from meta-analyses. All of these are based on a review of the scientific literature and making recommendations to you based on the evidence. So that should help you to reconsider what you're doing. Just like we know interventions to increase physical activity will increase function and mobility. That's been tried and true. And function-based research also increases physical activity, which we all know in rehab, like helping people be able to get up and get dressed. That's function-based research. But the Sentinel Alert back in September of 2015 and preventing falls and fall injuries from the Joint Commission was very clear. It was based on the same recommendations from David Oliver's article, the review of the science, that we should be working people up for individualized care planning based on fall and fall injury risk, protecting them from injuries, and making sure we do a really great job on post-fall analysis so we know why someone fell, and if someone was injured, what was the source of injury. All, again, based on additional literature that came out after the David Oliver article, but that's sentinel to the work from the Joint Commissions. And I helped write that for the Joint Commission in 2015 before I retired from the VA. So this article is also one of those high levels of scientific rigor based on a review of national data from the National Center for Healthcare Statistics. This came out of researchers from the CDC. They wanted to look and understand about the aging population in hospitals. And this was published in 2015, and I haven't seen any update on this about the age distribution in hospitals. We don't know this about rehab hospitals, but this is from the general population admitted in hospitals from 2000 to 2010. And what they wanted to focus on, colleagues, was people over the age of 85. So let me just briefly share with you the findings of this study. And it is fascinating, when they went into the national database, because some of my patients, my veterans, are in this database. Well, in 2010, 45% of the inpatient population was 65 and older. So why is that important? Because you can't base their care just based on someone being high fall risk on a screening scale. You're not going to protect them from falls. Once you start getting into people over the age of 65, they got lots of fall risk factors. When you look at the next finding of 20%, this is evidence, colleagues, almost 20% in 2010, and it's probably higher now. You should know the age distribution in your rehab hospital there in Indiana, but 20% almost was 75 to 84 years of age. Well, as you go up the pyramid, this is now the population where if they fall, they're a recurrent faller. So, stop just asking about fall history in the last 3 months or 6 months. These are people who we know are falling. But when you get to 75 to 84 years of age, we know this, colleagues. These are people who are also osteoporotic, anticoagulated, or they've already had a fall-related injury. So I'm taking you up the pyramid about who you have to protect in a different way. It doesn't matter what their score is on a screening scale. You know that they're fallers. I just took you to fallers, not fall risk, but also people who are at risk for injury. And then the next finding is your 9%, 85 and older. 9% of the patient population, almost 1 in 10, was 85 and older. So now I took you to the tip of my pyramid. In the tip of my pyramid, these are people 85 and older who, if they fall, they die. Their number one cause of unintentional injury, death, is a fall. That's not my research, that's CDC, and has been confirmed year after year after year. We know if someone's over the age of 85 and they're in your care and they fall, that their likelihood of surviving that fall is grave. So this population you have to protect in a different way. So you just can't implement interventions based on a score and a category of risk, like I said, low, moderate, or high. So every one of these populations, you now need to start not just asking about fall risk, fall history, but injury. You need to ask about injury risk and injury history. So what's important about this finding? Colleagues, this finding helps us to realize that in hospitals, we have a very different population than you will see in other settings of care. So the census, the US Census in 2010, the distribution of 85 years old in the US Census was only 2%. So I'm telling you that we had a higher density of people over the age of 85 that are very vulnerable in our hospital. So when you have someone based on vulnerability, based on injury risk, now you're starting to risk adjust. So after my talk today, maybe this week or next week, you will go back into your last year's age distribution and you find out, Joe's on this call with me, you find out what percent of your inpatient population at your rehab hospital was 85 and older. What percent was 75 to 84? Because you can't protect them if you're just implementing interventions based on low, moderate, or high fall risk. You're not going to do it. So there's my pyramid of level of risk. So you should know your level of risk. Everybody is at risk for falls. I'm having a call later today with a hospital where they're trying to start putting yellow gowns on people in the ER because they're high fall risk. It's like, what are you doing? You got to stop it. You got to stop focusing on color coding people who are at risk for falls, because everybody's at risk. Otherwise, you have a sea of yellow. The point is why are they at risk? That's the evidence. That evidence about practice goes way back, colleagues, that you just can't, bundling interventions based on universal fall precautions doesn't work. What does work is working people up. That's the evidence. That research has been tried and true. We also know as you move up the pyramid, as I mentioned, that the risk for injury and the loss of function increases for people as they age and have more comorbidities, more risk for injury, that as you go up the pyramid. So that's my 75 to 84-year-olds. And when you get to the tip of the pyramid, those are people, if they fall, they die. So who's another population? I give you my 85-year-olds, but I'm going to tell you, if you got a traumatic brain injury patient in your care that's already had a subdural hematoma and a craniotomy to do the surgical intervention for that, and falls and hits their head again, I mean, you know how bad that is. So you know the risk for loss of life. So what does that mean? That means that you have to protect people from injury. So that's why in all of your programs, there's a three-pronged approach, which is one of my objectives for you. We're all going to do all that we can to prevent falls, but you can't prevent them all. But you try to do what you can, but you're not going to be effective in just implementing universal fall precautions. It's not going to work. But if people do fall in your care, remember, you want to protect them from injury. So protection is shielding them from exposure, doing everything you can to reduce the amount of trauma that someone sustains if they fall in your care, so that you can make less the severity of injury, so that you reduce the loss of the severity of the injury and loss of life. And then you've got to keep eyes on patients, and that's what surveillance is about. And that's why the telesitter technology has been so successful. So the national guidelines have shifted. All of you, this is based on the evidence, ladies and gentlemen, that all of you should be reducing individual fall and injury risk factors. That means you have to have an individualized care plan. You've got to integrate injury risk and history into your admission assessment process. That dates back to the Joint Commission Sentinel Alert in 2015. That's now 7 years old. You've got to implement universal injury prevention strategies. When I do rounds in hospitals, I look for the risk of injury, not just the risk of falls. So what am I going to do to create a safer environment and reduce the risk of injury? And then you have to implement a population-based approach to injury reduction, because every population is not the same. You can't treat everyone as if they're the same, and then reduce harm from falls. So implementing this population-specific fall injury reduction strategy was part of the Joint Commission's Sentinel Alert back in 2015. So let me share the first exemplar. My first exemplar is moving you to a population-based approach to injury reduction. There are three population-based approach injury reduction strategies that I'm going to share with you: the ABCS, the floor mats, and the hip protectors. And hopefully you know about all of them. So let's get into this ABCS. You know what? This work started over 10 years ago with IHI, the Institute for Healthcare Improvement. And I know that some of you on this call remember the TCAP program, Transforming Care at the Bedside. Well, Pat Rutherford was a vice president of IHI at the time, back in 2006, and she contacted my Patient Safety Center because we had won the Magnet Prize Award. We won the very first Magnet Prize Award in 2003. And she knew of our work in protecting people from injury, and she wanted to do something totally transformational for medical surgical units. Because on medical surgical units, unlike rehab, their length of stay is 72 hours. So you just can't focus on trying to implement a fall prevention care plan. When they come in, you got to start right away to protect them from injury when they come into their care. So we launched this whole project on reducing serious injuries from falls on medical surgical units. And we came up with 4 populations where if they fall, they have loss of function or loss of life. So this is at the tip of the pyramid. One is age, one is bone, one is anticoagulated, and one is surgery. So there are 4 populations. Of course, there's others that are out there. But you know what? This has all been published. This was published back in 2008. I'm the only one that published a site visit. My hospital, I was the clinical lead on it, but my hospital was the only VA that was part of this project. And we are the only hospital that actually published our findings. And then this has been tested. We had an implementation guide that we launched in the VA based on this population-based approach to injury reduction. and tested it. We gave out the guide and tested it throughout the Department of Veterans Affairs and long-term care settings. I think it was 57 hospitals or long-term care settings. So here's the age. People over the age of 85, if they fall, they die, remember? So you got to protect them. It doesn't matter what their score is on a screening scale, but if they fall, it could be the loss of their life. So there's a bundle of interventions that you implement for people over the age of 85. So this is where you start getting into a population-based approach to injury reduction. What do you do for people over the age of 85? So you have your fall prevention program, but now for your 85-year-olds, this is what you have to launch. So you've got to have hip protectors. You've got to have floor mats. You have to have height adjustable beds, safe exit sides. People know what side of the bed to get out of, and that's the side of bed that you floor mat. And all of these interventions, as I share these with you, here's the bones. These are people, if they're osteopenic, osteoporotic, if they've already had a fracture, you've got to implement interventions to protect them from fracturing again. So what you do for protecting people from fracture is going to be different than what you do for people who are over the age of 85. So all of these interventions for these three populations were validated through expert opinion at one of my Falls conferences. We sent all of this out for confirmation at our Falls experts who came to one of my Falls conferences, and that's how we did face validity on these. People who are anticoagulated, what you've got to do for them, you've got to protect them in a different way, because if they fall, they're going to bleed. Patient education, your helmets, your anti-tippers, and wheelchairs. So these people have to have helmets, and there's new helmets out there. Joe knows that we presented it last year on rib cap helmets that are very protective, and they don't have the same barriers as the helmets that we've been using in rehab. Surgical patients, you know, if surgical patients fall after surgery, that they're going to dehiss and end up back in surgery. So, I mean, this is common sense. As clinical experts, we know that each one of these four populations are different. So we tested these. We tested them on large scale in the Department of Veterans Affairs, as I mentioned to you, in state veterans homes. And we also did breakthrough series with lots of organizations in the VA. And we published this work in 2016 and again in 2018. So to my knowledge still, the only hospital that has actually implemented the evidence-based fall prevention program going back to the ABCS, I'm just going to take you right back there real quick, is Mount Sinai in New York. The VA, we've got our guide out there. We've got all this work that we have done, stuff that we have implemented in the Department of Veterans Affairs. We've got all this work, but only one hospital that I know of that actually implemented the ABCS. And her name, the nurse executive, is now the nurse executive of the entire healthcare system. Her name is Maria Vizina. She's fabulous. I have a podcast coming out that I interviewed her with a company. So, I mean, she is the only one that said, we're not going to waste all of our time doing all this screening stuff and scales on every shift with the Morse scale. We're going to just go right after people over the age of 85. We're going to protect people right away that came into our care and they're osteoporotic. People are anticoagulated. What are we going to do if they fall to protect them? And certainly people are post-op. So I share this with you because it's up to you to implement the evidence into practice. Floor mats. Are you using floor mats? Joe, can you nod your head yes or no? Because I can see you. Are you using floor mats? Yes. Okay. So Joe said we're using floor mats. So how do we get to floor mats? Well, floor mats have been used a long time. I'm not going to go over all of this, but floor mats have been used for a long, long time in lots of ways. But what was new, and even with the guidance that's out there from the National Floor Safety Institute about using this, was being able to use floor mats to help reduce slips and trips and falls. But what had not been done was to be able to use floor mats at the bedside to reduce injury. So this work started at my Patient Safety Center over 10 years ago, 2007, as the one intervention that we were implementing on our medical centers and long-term care settings, because we wanted to make sure if someone fell from bed, that we would protect them from injury. No one had ever done this before. That launched from my setting. So we looked at all different floor mats out there. We started doing impact testing. We tested all of this through biomechanical research. So when you're looking at research science, when you're testing interventions, you rely on biomechanical research, not a randomized controlled trial. So that's why I challenge you have to know the strength of the evidence. So we conducted the biomechanical research. We did simulation research. We tested different levels of height, simulating from a bed with instrumented mannequins, different levels of height. And during the fall, we knew that even with mannequins, that the head surface would actually onto the floor would go past the floor mat. So we knew we needed to look at the dimension of the floors because we tested it with a floor mat down versus unprotected flooring. So we know the issues surrounding furniture at the bedside. You have to move furniture on the safe exit side, but the criteria that we used for impact testing was head injury criteria that they used for airbags and also helmets. So we tested it. And what we found, and we published this in the Journal of Rehabilitation Nursing back in 2008, I think it was, that if you have someone who falls from a bed onto the floor with no floor mat down from a high level, like falling over the rails, that they have about a 40% chance of having a serious head injury. But if someone falls from a low bed onto a floor mat, you reduce that severity of a head injury to 1%. So, I mean, that is so protective. So, you know what? There's other research that's been published that shows how protective floor mats are to protecting from hip fractures and pelvic fractures. But, you know, we know that if someone falls onto a pad, that it's going to reduce the force of trauma. So biomechanical forces can be minimized. You have to height adjust the bed. People should only be in low beds when you're worried that they're going to roll out of bed, but you got to height adjust the bed for someone to stand up, lowering the rails. But floor mats absolutely decrease the impact of a fall. So it's now a standard of care based on the level of scientific rigor of biomechanical testing that floor mats should be down. This is the article I mentioned in 2008. I was right. That was good in rehab nursing. But we published this. I mean, we have presented this all over the place. But you know what? We even have a toolkit. And that's how you translate evidence into practice, is now you take the toolkit and you disseminate it. It's one thing to publish in the literature. It's a whole other thing to actually roll it out into practice. That's the hard work. And we did it. You know, if you were to look to any VA medical center within the care planning process, is it time for me to go, Joe? Is that what you're telling me?
No, I just wanted to clarify for our use of mats for the audience, Pat. We use it in our restraint population when we have to take them out of restraint and we know they like to exit or are impulsive, but we don't necessarily use it on all our fall patients. So I wanted to be sure they were clear on when we use them currently.
So you may change that after this.
That's right.
Yeah. So you may change this because floor mats should be down for anybody who's at risk for getting injured if they fall from your bed. So floor mats are based on, you know, people who you worry are going to be not full partners in your fall prevention plan of care, and they could get injured if they fall from your care. So the guidance now is that is a standard of care, is to have a floor mat at the bedside for people that you worry are going to get injured. They're osteoporotic, they've had a head injury, they've already had a fracture injury. But my point is that you want to protect from injury, you know, and the floor mats can be placed at the bedside, but also in front of a chair. So there's resources that are out there, you know, different kinds of floor mats. But what I wanted to say too is that there actually is a new floor mat that's out now, because our biggest barrier to floor mat use, even though they're protective, is people worry about tripping. So there's a new floor mat now. If you want to learn about it, just let me know, Joe. But there's beveled edges on all four sides. You leave it down all the time. You don't pick it up and move it. It has no stitching on it, so there's no issues with infection control. They've been eliminated. And it has memory foam. So people, if there's multiple impact on it, it still is protective. So all of that is launching. So even though I'm sharing with you research that we have done, and we know that floor mats is your best intervention now to protect from injury when people fall from beds or fall from chairs, is that there has been so much resistance. So now there is a new solution to eliminate that resistance, because our goal is to create a safe environment for everybody. That's what you want, because you don't want people to get injured. And that includes, you know, not just head injuries and hip fractures and pelvic fractures. You know, people break their wrists and their elbows when they fall, their shoulders too. So there are new resources that are out there, but that's number two. So number one is your ABCS. You have to go after specific populations. And then your next intervention is floor mats. Your floor mats is your most protective intervention now. So if someone actually was to fall from bed, you want to make sure that they fall onto padded flooring. So that's where you can set a goal, is that every patient who falls from a bed falls on a floor mat, because then you're ultimately reducing severity of injury. So then there's hip protectors. This is number three. So how did we come up with hip protectors? Well, we had a nurse manager in a dementia unit in a brand new long-term care facility in Orlando. And she had a veteran who could walk and already had a hip fracture. And she was so worried that he was going to fall and break a hip again. So she found the hip protectors starting to be used in the UK. So we thought, oh my gosh, if we could put padded floor, well, we're going to put padded flooring on the floor with a hip floor mat, but now we need to pad someone up. So remember, how you protect someone with a hip fracture risk is different than someone who falls from bed, because there's lots of ways to fall and break a hip. When you're walking, transferring out of a chair, getting on and off a toilet. I have a case right now. Someone who tried to sit down on a toilet that was too low, insufficient grab bars, fell off the toilet and landed on his in the bathroom and broke his hip and his shoulder. Terrible. So, hip protectors actually work. So we conducted the science because that was our job. When you looked at the science that was out there, there was only very, very few descriptive studies that were biomechanical impact testing of the hip protectors. So it was our job to conduct the research with different kinds of hip protector clothing that was out there. So we worked with all the companies. We knew the different kinds of hip protectors that are out there, soft shelled, hard shelled, and a combination of them embedded into clothing. So we wanted to test them, and we did the impact testing just like we did the impact testing with the floor mats. We actually had simulation research that we did. We know that, again, there's lots of directions for someone to fall and break a hip. That's all been laboratory tested. We know it's tried and true. Going down the stairs is worse than climbing up the stairs for someone having the risk of breaking a hip and how they turn. So we did the impact testing of the hip protectors. We brought companies together. We got multiple vendor products, and we went off and tested them. We published this in 2008 in Clinical Interventions in Aging. So again, this is over 10 years old that we were able to show that hip protectors actually work. We even did laundering studies because we sent these out to veterans who came into my falls clinic and have them wear these at home, and how durable are they after multiple impact, and how many laundering cycles could they go through and still be protective. So we did all that research, and we showed that they were indeed protective. This is a device that we use to do the impact loading and breaking, if you will, enough load to be able to break a healthy hip. And how protective were the hip protectors to absorb that trauma so that someone doesn't have to have a hip fracture if they fell. I believe if Jimmy Carter had been wearing hip protectors when he was out playing golf, he wouldn't have broken his hip. I just had a conference call yesterday with someone that I know that's an editor of a journal who broke her hip in January. Now I'm telling her now that she needs to start wearing hip protectors. So I'm telling you that they work. So we did the baseline tested. We knew how much force there was needed to actually break a healthy bone, and we knew what we needed to do to be able to protect them. So we know the force and the impact that's required to be able to protect someone no matter how they fall. So we know with all the impact testing that we did, the attenuating properties, and that means that it absorbs the trauma and takes that trauma away, is indeed protective. But the degree of degradation differs with the different protectors. So we published that work. But we knew in testing all the different pads and multiple parts of the pad as it protects the head of the trochanter, that they were indeed protective to be able to not have a healthy bone break if they were to fall onto the floor mats. So what we did is we published that. We made that available. We created the toolkits again, just like we did the floor mats. And then we rolled it out. We created posters. You'll still see them on the VA website now. We created posters, we created pins, we created brochures, all this stuff that we did to do national dissemination. And if you were to go again to any VA fall prevention, injury prevention template, you would see a floor mat that's an intervention and a hip protector that's an intervention. So what does that mean? That means for any veteran at any point in care, if it's in a national template, that if they need a floor mat, it's going to be made available to them. If they need a hip protector, it's going to be available to them. So it's based on the patient. It's based on their risk for injury. But the point is once you conduct the research, you know how protective they are, you launch all the education after you've created the policies and the procedures and the standardized templates to make it work, and then you roll it out. But even just rolling it out, with anything that you do, you have to keep on top of it, because staff change, leadership changes, and people will drift back to what they've always been doing. So there's always a lot of work when you're taking the research to evidence and trying to integrate that evidence into practice. So there you see the hip protector toolkit. We have developed everything, the policies, the procedures, the templates, how to be able to do social marketing to patients to try and get them to use them. And they work. But will people wear them? That's the art and the science of nursing. I can talk anybody into wearing a hip protector. I'm really good at it. But people learn those skills because just like getting someone to use their cane or their walker, we have lots of people who resist it. But it's not just at the patient level. For us in care, we have to work with staff because a lot of people will resist change too, and using technology that we actually know knows work. But because there is so much evidence out there, when the Agency for Healthcare Research and Quality, or excuse me, the Institute of Medicine, this is the Institute of Medicine, when they published their second Making Healthcare Safer report in 2013, this is how many years old? 9 years old. In their chapter 19, for preventing in-facility falls, the only intervention that they included based on the evidence was hip protectors. And this is for acute care hospitals. So where are your hip protectors? So my point is that this is tried and true. So how do you take evidence and implement it into practice? That's your responsibility. If you know it works, how can you not be doing it? Because once it becomes a standard of care and you have people who fall in your care and you're not implementing any injury reduction strategies and they have a head injury, a hip fracture, then that's what becomes litigious. So it's all about shifting practice, colleagues. So I hope I can go with other examples too. And I will also tell you, I told you that there's new floor mats that are out there. There's new hip protectors out here. Joe knows this. We presented 2 years ago on a whole new hip protector called Tango Belt. It's an airbag. It's a belt that goes around the waist, and it has an airbag that deploys once there's just the force of velocity that someone's starting to fall. So if you don't like the clothing, go look at what's new out there. But I believe in choices. So that's why I stay up on interventions and innovation, because all of us have a responsibility to reduce falls from reducing falls to protecting people from fall-related injury. It's the injuries that result in loss of function. All of this is what's guiding CMS. CMS for years now, it really started in the very first work with patient safety organizations, the hospital engagement networks. They were supposed to reduce injurious falls, but it was so hard to do. No one was implementing any injury reduction strategies except for the VA. So they drifted back to looking at falls. But I think it was 2018, that CMS was very clear, 2019, that they were going after injuries. So that was the measure of performance that they were really looking at, is protecting people from harm, any harm in our care. So reducing falls and protecting from fall-related injury is the shift. So that means you have to integrate injury risk and injury history into your admission assessment process. It is not enough to just ask about fall history. If someone says that they've had a fall and they get a yes, you have to ask, how many falls have you had? What are the circumstances? But then if someone says that they've fallen, you have to ask the next question, have you been injured as a result of a fall? And even if someone says that they haven't had an injury, you have to ask about injury risk. So you should know, go back into your electronic medical record again. I gave you a challenge. Go back and look at your age distribution. Go back and look at how many patients are on bisphosphonates in the last year. And you'll know what % of your population is osteoporotic. If they fall, you got to protect them from injury. So that's who gets a floor mat at their bedside, is anyone who's osteoporotic, they're osteopenic, or they've already had a hip fracture. They've had any fracture, a spine, a wrist fracture, an elbow fracture from a fall. So you have to ask about injury risk, and you have to ask about injury history on admission. You have to embed that into your care planning, and then implement your universal injury reduction strategies and go after a population. Pick one. You don't do all 4, A, B, C, or S, but pick one and do something to protect them in a different way than what you're doing now. So that's why you've got to do injury risk assessment. You've got to implement injury reduction interventions, and then you have to go after specific injury risk. What do you do for someone who's anticoagulated versus the osteoporotic? So that's what you put in place. And that's why it made it to all the national toolkits, because of the evidence to be able to protect people from injury. So you've got the work that, from IHI and ARC, the Agency for Healthcare Research and Quality, or their fall prevention toolkit, the 2014, that's going to be updated in this coming year. The work from the VA, the work from the Institute for Clinical Systems Improvement, and IHI. I mean, it's made it into all the toolkits, and you'll see it in all the literature. So I hope that this shift is helpful to you as I share with you about the evidence. I've shared with you the research that's been done on a snapshot with the time that I had, but because there's so much evidence that these are protective, it's up to you to implement them. So, reducing falls and protecting from injury is what we want you to do, integrated into the injury assessment, universal fall precautions, and population based. So in my world, this is the reason why I fall. They're with me right here. Is my boys. So I've got Oreo over here, Jethro back over here. They're Basset Hounds. Oreo's a Basset Hound mix. So I know why I fall. But you know, every patient, you got to know what are their fall risk factors. So Joe, I hope that this has been helpful, that you will commit to change, that some of you I know are champions for change that are listening to me. But know that I'm here for you. And if I can help you in any way, you always have my email. So with that, I'll turn it back over to you, Joe.
Thank you, Pat. I'm been looking for questions in the chat. I haven't received any specifically at this time. I am getting thank yous from people for your excellent presentation, Pat.
You're so welcome.
If anyone has a question, please send it into the chat here quickly and we'll get Pat to answer. And again, I want to thank you, Pat, for being my friend and colleague and supporting me in my work.
Always. Oh, Dawn, you're so welcome. Thank you. I do hope that this will help you look at how you can use floor mats more, though. But if you want to look at the new floor mat, let me know.
Well, you know, I don't hesitate to call you.
Yeah. You're welcome, Kristen and Darlin. Yeah, you're so welcome. Anything I can do to help you. But, you know, protecting people from injury is our moral imperative, because it's injuries that result in loss of function, loss of life. You and I fall, and thank goodness for me, I'm almost 70 years of age, but I'm still getting up after I fall. You know, there come a time that I may not, but, you know, for all of us, we want to be able to do all we can to be able to protect people.
Well, Pat, I'm known as a repeat faller here. So they surround me with yellow tags and bubble wrap.
Well, that's who gets the armband. It's not someone who's high fall risk. It should be someone who came into your care because of a fall, or someone who has injury risk factors or an injury history. That's who should get the armband. Make it meaningful, not something that doesn't have any meaning when you put armbands on people who are high fall risk. Well, you all are so welcome. Thank you so much for inviting me, Joe. I hope you have a wonderful rest of your Nurses Month for our nurses that are here. And for every one of you, you know, pray for all of these people in Ukraine, please do, especially everyone, but think of the Ukrainian nurses. I've been really trying to do all that we can to really think of the nurses there, but thank you so much, Joe. And join Rehab Nurses if you in the Rehab Nursing Association with Joe and I. Our doors are open, so we invite you.
Thank you, Pat.
You're welcome, Joe. Thank you so much. And I want to thank as well Judy Router for all she did to support me. Judy, I know you're there. You got your, you know, you're muted, but thanks for all you did to support me as I prepare for this presentation. Thank you, Judy. Okay, I'll hang up now then.